Hey there. Welcome to this deep dive. We're going beyond textbooks this time. We're looking at medical school notes.
Yeah, specifically cardiology and respiratory medicine.
It's the stuff that makes you the most interesting person at parties.
Oh, for sure. Like at your next doctor's appointment, you can be like, well, actually.
Oh, absolutely. These notes are amazing. They go way beyond the basics.
Yeah.
We're really getting into like the nitty-gritty, how doctors actually diagnose and treat these conditions.
Exactly. We're talking about everything from hypertension to some rare diseases like Takayasu's arteritis. But the best part is how these notes connect all these seemingly unrelated symptoms and offer clinical insights you just wouldn't find anywhere else. Okay, so our first section is Decoding the Heart's Whispers, Understanding Cardiac Symptoms. I'm already intrigued.
Well, me too. This section is all about understanding the language of the heart. Especially chest pain. It's not always a straightforward heart attack situation.
Okay, so what are doctors looking for? When a patient comes in complaining of chest pain, well, it's like detective work. The notes emphasize duration. Is it fleeting or is it lasting for hours? Location is key too. Is it centered over the heart? Radiating to the arm? Or is it more diffuse? And maybe most importantly, does it change with rest or medication?
So they're piecing together a puzzle with all these clues.
Exactly. And there's this fascinating thing called Levine's sign. Just imagine someone clenching their fist over their sternum when they're describing angina pain.
Oh, wow. I can feel it just thinking about it. It's amazing how such a simple gesture can be so significant.
Yeah, it's incredibly common, and a strong indicator that the pain is coming from the heart rather than the lungs or muscles.
That's incredible. Now, what about shortness of breath? The notes mention dyspnea. Is that just a fancy word for it?
It is, but there is a reason for that fancy term. Shortness of breath can be a sign of so many things, from heart issues to lung problems. The notes explain how it manifests differently. Imagine someone gasping for air. After a sudden pulmonary embolism, that's acute dyspnea. But then you have someone with chronic heart failure who's constantly short of breath with any exertion. Totally different scenarios, yet both involve dyspnea.
So even something as simple as breathing can have hidden complexities. And speaking of unexpected connections, the notes point out that even a nocturnal cough can be a cardiac symptom. Who would have thought?
Right, it seems counterintuitive. But when you lie down, fluid can shift back into the lungs, especially if your heart isn't pumping efficiently. That fluid buildup can trigger a cough, particularly at night.
It's like your body is trying to tell you something's wrong.
Okay,
So let's shift gears to a silent threat, pulmonary hypertension.
Okay. The notes define this as a mean pulmonary artery pressure of 20 millimilli Hg or higher, and it's called a silent threat because it can damage your heart and lungs for years without obvious symptoms in the early stages.
So you might not even know anything's wrong until there's significant damage.
Yeah, unfortunately, that's the case for many people. But here's where it gets interesting. You know how calcium channel blockers are used for high blood pressure? Well, they're surprisingly effective for certain types of pulmonary hypertension, too.
That is surprising. Why would a medication for high blood pressure work for a lung problem?
Well, it all comes down to the role of calcium in vascular smooth muscle contraction. Calcium channel blockers relax the smooth muscle in the blood vessels, which lowers blood pressure. And in certain types of pulmonary hypertension, this same mechanism can help reduce pressure in the pulmonary arteries, which improves blood flow and relieves strain on the heart.
So it's not just treating the symptoms, but the underlying cause.
Exactly.
That's incredible. Speaking of underlying causes, the notes don't hold back when it comes to atherosclerosis, calling it the most common cause of heart disease.
Absolutely. And what's scary is how subtly it starts. It starts with damage to the inner lining of your arteries, like a tiny crack in a bridge. That gets bigger and bigger over time.
And I'm guessing that crack eventually becomes a major problem.
Oh, yeah. That initial damage allows cholesterol and other substances to build up, forming plaque, which hardens and narrows the arteries.
Okay, that makes sense. But the notes also distinguish between stable and unstable plaque. What's the difference?
Imagine those plaques as ticking time bombs. Stable plaques are relatively calm, not likely to cause any immediate trouble. But unstable plaques are like a bomb with a loose wire. They're very prone to rupturing.
And when that happens, what are the consequences?
Oh, it can be an emergency. When an unstable plaque ruptures, it triggers a blood clot, which can block blood flow to the heart, causing a heart attack, or to the brain, leading to a stroke.
Yeah, it's terrifying. It makes those lifestyle choices like smoking and a bad diet even more dangerous.
Oh, absolutely. Those choices directly contribute to the development and progression of atherosclerosis.
Okay, well, on that sobering note, let's move on to section 3. which focuses on peripheral artery disease, or PAD. No surprise, the notes point out that 90% of PAD cases are caused by, you guessed it, atherosclerosis.
Right. It's not just the heart that atherosclerosis affects. It can impact arteries throughout the body. And when it hits the legs, we call it PAD.
The notes mention something called intermittent claudication, or window shopper's disease.
Yeah.
Is that an actual medical term?
It is. It's a classic symptom of PAD. Leg pain forces people to stop walking, often in short intervals. Imagine having to stop every few blocks just to catch your breath. It can make even simple errands a real struggle.
So it's not just about the physical pain, but also the impact on your daily life.
Exactly. Now, on the other end of the spectrum, we have critical limb ischemia. This is where the pain is constant, even when resting. And there's a real risk of losing a limb.
That sounds scary. How is that treated?
Well, the notes emphasize early detection and treatment are crucial. A simple test called the ankle brachial index, or ABI, compares blood pressure in the arms and legs and can help identify circulatory problems early on.
It's amazing how something so simple can provide so much information.
It is. And sometimes lifestyle changes and medication can help. But in severe cases, procedures like angioplasty or bypass surgery might be necessary to restore blood flow.
Okay, now this is the part that both fascinates and terrifies me. Section 4 is all about diseases of the aorta, the body's largest artery. We're talking aneurysms, dissections, the stuff of medical dramas.
Aneurysms are essentially bulges in a weakened wall of the aorta. Imagine a balloon that's been stretched too thin in one spot. That's what an aneurysm looks like.
And those can rupture, right? That's what I always see on TV.
That's right, and it can be life-threatening. But what's interesting is that thoracic aortic aneurysms, the ones located in the chest, often have subtle symptoms that you might not immediately associate with a heart problem.
So what kind of symptoms are we talking about?
Things like difficulty swallowing, hoarseness, or even back pain. You wouldn't think those were related to your aorta, right?
Absolutely not.
But it's all about location. The aorta is close to other structures in the chest, so as it enlarges, it can press on them, causing those seemingly unrelated symptoms.
It's like a domino effect. One problem triggering others. Now, what about aortic dissection? The notes describe that pain as a classic ripping sensation.
Yeah. Imagine a zipper suddenly unraveling inside your chest. It's a pretty accurate analogy. That's what happens when blood tears through the layers of the aorta, leading to internal bleeding.
It's no wonder the notes emphasize the need for immediate medical attention.
It is. Aortic dissection is a true medical emergency. But on a slightly less intense note, let's move on to Section 5, which covers congenital heart defects.
Okay, so these are heart defects people are born with.
Exactly. And the notes categorize them into two main types, acyanotic and cyanotic, based on whether they cause that blue baby appearance from low blood oxygen levels.
So acyanotic defects don't cause the blue baby appearance.
That's right. They involve left to right shunts, where blood flows from the left to the right side of the heart, but it doesn't really affect the oxygen levels in the blood.
The notes mention things like atrial septal defects, or ASDs, and ventricular septal defects, or VSDs. Are those examples of acyanotic defects?
They are. Imagine a wall separating two rooms, but there's a hole in it. That's essentially what an ASD or VSD is, a hole in the wall separating the chambers of the heart.
And how does that affect the heart?
Well, even though they don't cause the blue baby appearance at first, these defects can lead to problems later on. The extra blood flowing through that hole can strain the heart, leading to enlargement and even pulmonary hypertension.
So even minor defects can have long-term consequences. What about patent ductus arteriosus, or PDA? I've heard of that one, but I'm not sure what it is.
So in babies, there's a blood vessel that bypasses the lungs before birth. It's supposed to close after birth, but in PDA, it stays open. Now, you might think that's a bad thing, but sometimes keeping this open can be life-saving, especially for babies with other serious heart defects.
That's incredible. It's like turning a problem into a solution.
Exactly. It just highlights the complexity of congenital heart defects and the amazing interventions that are available.
What about cyanotic defects? The notes mention tetralogy of Fallot as an example.
Yeah, tetralogy of Fallot is actually a combination of 4 specific defects that together restrict blood flow to the lungs, causing low blood oxygen and that characteristic blue baby appearance.
I remember seeing an X-ray of this once. The heart had a really unusual shape.
Yeah, the notes describe it as a wooden shoe appearance.
Yeah, I can picture that. The notes also talk about hypoxic spells that babies with this condition can experience.
Hypoxia means low blood oxygen levels, and these spells can be pretty frightening. The baby might suddenly turn blue and have difficulty breathing.
That sounds terrifying. How are those spells treated?
One of the surprising treatments mentioned in the notes is morphine.
Morphine. But isn't that a pain medication?
It is, but it also has other effects. In this case, morphine can relax the narrowed portion of the heart muscle that's restricting blood flow to the lungs.
So it's not about pain relief, but about improving blood flow.
Exactly.
That's amazing. Okay, I think we're ready for section 6, which tackles valvular heart disease and rheumatic fever.
All right. This section delves into the world of heart valves. You know those intricate structures that control blood flow through the heart? When those valves malfunction, it can cause all sorts of problems.
So what kind of malfunctions are we talking about?
Well, the notes describe two main types, stenosis and regurgitation. Stenosis is like a narrowed doorway. The valve doesn't open fully, restricting blood flow. Regurgitation is like a leaky faucet. The valve doesn't close properly, allowing blood to flow backward.
I bet those malfunctions sound different too, like you could actually hear them with a stethoscope.
Oh, you're absolutely right. Listening to the heart sounds, or auscultation, becomes a crucial diagnostic tool. Each type of malfunction produces a distinct sound.
It's amazing how much information doctors can get just by listening. Now, the notes also discuss rheumatic fever, which I remember as a kid being told was a serious complication of strep throat.
It is. Rheumatic fever is an inflammatory condition triggered by untreated strep throat. And it can affect multiple systems, from the heart to the joints to even the brain.
The notes mention something called migratory polyarthritis, which sounds incredibly painful.
Imagine joint pain jumping from one location to another. That's migratory polyarthritis. It can be incredibly debilitating and hard to diagnose because the pain keeps moving.
And what about the brain involvement? That sounds even more worrisome.
Right. One potential complication is Sydenham's chorea, a neurological disorder with involuntary movements. Imagine experiencing uncontrollable twitches and jerks. It can be really distressing for patients and can even have long-term consequences, affecting coordination and fine motor skills.
It's a stark reminder of how those simple infections like strep throat can have such lasting impacts on the body.
Okay, let's move on to section 7, which focuses on pericarditis and myocarditis. I have to admit, I'm not familiar with those conditions.
Oh, okay. Pericarditis is inflammation of the pericardium, the sac that surrounds the heart. Imagine a delicate balloon. That becomes irritated and inflamed. It can cause sharp stabbing chest pain. That's worse when lying down.
I can imagine. And here's another interesting detail. This pain is often better when the person leans forward. It's a classic sign. That can help doctors differentiate it from other types of chest pain.
So the position of your body can influence the pain.
It can. And in some cases, pericarditis can lead to a buildup of fluid, a condition called pericardial effusion. Now, that might not sound too serious, but it can potentially lead to cardiac tamponade, which is life-threatening.
I've heard of cardiac tamponade, but I don't really understand it.
So imagine that balloon surrounding the heart filling up with fluid. As the fluid accumulates, it starts squeezing the heart, preventing it from filling and pumping, like a boa constrictor tightening its grip.
That sounds incredibly dangerous. Are there any warning signs?
The notes mention process paradoxus, which is a drop in blood pressure when you inhale. It can alert doctors to this complication.
So even seemingly small changes in blood pressure can be a red flag.
They can. Now, myocarditis involves inflammation of the heart muscle itself. It's often caused by viruses, especially in infants.
So a common cold could lead to myocarditis.
It's possible. That's why it's so important to recognize early signs, like rapid breathing and poor feeding in infants. Myocarditis can become serious quickly.
It's a good reminder that even minor illnesses can have consequences, especially in young children. All right, let's move on to section 8, which tackles cardiomyopathies.
Okay, cardiomyopathies are diseases of the heart muscle, affecting the heart's ability to pump blood. The notes classify them into 3 main types: hypertrophic, dilated, and restrictive.
So it's not just inflammation, but about the structure of the heart muscle itself.
Exactly. Hypertrophic cardiomyopathy is where the heart muscle becomes abnormally thickened, particularly in the left ventricle. It's often seen in young athletes and can sadly lead to sudden cardiac death during exertion.
That's terrifying.
It is. It's a tragic reminder of the importance of screening young athletes, especially those with a family history.
The notes specifically caution against using digoxin for these patients. Why is that?
Well, digoxin helps the heart pump more forcefully. But in hypertrophic cardiomyopathy, the problem isn't weak pumping, it's the thickened heart muscle. Digoxin can actually worsen things by increasing the force of contractions in an already stiff ventricle.
So it's not a one-size-fits-all approach with medication.
Exactly. Now, dilated cardiomyopathy Involves enlargement and weakening of the heart chambers. Like the heart muscle is stretched too thin, like an overinflated balloon.
So the heart is bigger but weaker.
That's right. And the causes can vary from viral infections to nutritional deficiencies to alcohol abuse.
It's incredible how many things can affect the heart. What about restrictive cardiomyopathy?
Restrictive cardiomyopathy is the rarest type. It involves stiffening of the heart muscle. It's like the heart walls have become rigid, preventing the chambers from filling properly.
So even though the heart muscle might be strong, it can't relax.
Exactly. And unfortunately, the treatments are limited. Medications can help manage symptoms, but often a heart transplant is the only option.
Okay, moving on to section 9. We're facing a silent invader infective endocarditis.
This is a potentially deadly infection of the heart's inner lining, the endocardium. And what's scary is that it can start from something as simple as dental work.
Wait, going to the dentist can lead to a heart infection.
It's possible, though rare. Bacteria from your mouth can enter your bloodstream during those procedures, and in people with pre-existing heart conditions, especially those with artificial valves. Those bacteria can attach to the heart lining and cause an infection.
So even routine dental care can be risky for some people. What can be done to prevent that?
The notes emphasize antibiotic prophylaxis, basically taking antibiotics before certain dental procedures. It's a simple precaution that can make a big difference.
That makes sense. Are there any warning signs of endocarditis?
The notes mention a new heart murmur, unexplained fever, or even fatigue. It's important not to ignore these signs, especially after any invasive procedure.
Okay, that's good to know. Section 10 takes us back to the legs, chronic venous insufficiency and deep vein thrombosis. I'm familiar with varicose veins, but I'm not sure what chronic venous insufficiency is.
Think of it this way. Your veins have tiny valves that help keep blood flowing up to your heart, working against gravity. In chronic venous insufficiency, those valves become weak and leaky, causing blood to pool in your legs.
So instead of flowing upward, the blood backs up.
Exactly. And those familiar varicose veins are actually a visible sign of this. They're like swollen, twisted rivers of blood.
I've also heard of spider veins. Are those related?
They are. The notes describe spider veins, or telangiectasias, as the mildest form. They're those tiny web-like veins that often appear on the legs. As the condition progresses, those veins get bigger and more prominent, leading to those bulging, ropey, varicose veins.
So it's a spectrum from tiny spider veins to large, bulging veins.
Exactly. Now, deep vein thrombosis, or DVT, is totally different. It involves a blood clot forming in a deep vein, usually in the legs.
I know DVT can be dangerous because the clot can travel to the lungs.
That's right. A pulmonary embolism, where a clot breaks loose and lodges in the lungs, can be life-threatening. And the notes delve into the factors that contribute to BVT, using something called Virchow's triad.
Virchow's triad? That sounds intriguing.
Imagine a three-legged stool. Each leg represents a factor that can contribute to DVT: stasis, hypocoagulability, and endothelial damage.
Okay, so what do those terms mean?
Stasis is slow blood flow, like what happens on long flights. Hypercoagulability means your blood clots more easily, which can be caused by medication or genetics. And endothelial damage refers to injury to the lining of your blood vessels, which can happen from trauma or inflammation.
So it's not just one thing, but a combination of factors.
Exactly.
I'm starting to see why these notes are so fascinating. They take these complex ideas and break them down. Okay, so Section 11 tackles a condition I hear a lot about, but don't fully understand: heart failure.
Okay, it's a common misconception that heart failure means the heart has completely stopped working, but it actually means that the heart isn't pumping as effectively to meet the body's needs.
So the heart is still working, just not as well.
Right. And the notes introduce this concept called ejection fraction, which measures how much blood the left ventricle pumps out with each heartbeat.
So it's a measure of the heart's sufficiency.
Exactly. Imagine your heart is like a water balloon. The ejection fraction is the percentage of water you squeeze out each time.
That's a great analogy.
A normal ejection fraction is between 50 and 75%. So if it drops below that, it means the heart isn't pumping as well.
And what causes that drop?
It can be caused by lots of things: coronary artery disease, high blood pressure, heart valve problems, even some viral infections.
So lots of things can lead to heart failure.
Yeah. And the notes go into the neurohormonal changes that happen in heart failure, explaining how the body tries to compensate, but ultimately ends up making things worse.
So it's a vicious cycle.
Right. And the notes also highlight the common symptoms of heart failure, like shortness of breath, fatigue, and swelling, emphasizing that those can vary in severity and impact quality of life.
It sounds debilitating.
It can be. especially in the later stages. But with early detection and treatment, many people can live normal lives.
Okay, let's switch gears to the respiratory system. Section 12 starts with asthma.
Asthma is a chronic inflammatory disease that affects the airways. Those tubes that carry air in and out of your lungs, imagine them becoming inflamed and irritated, making it difficult to breathe.
I know asthma attacks can be scary.
They can be. And what's interesting is that the notes highlight how the airway inflammation can continue even when you don't have symptoms. So even if you feel fine, the underlying inflammation can still be causing damage.
Like a silent threat.
Exactly. That's why long-term management is so important.
The notes also talk about occupational lung diseases. I'm guessing these are conditions caused by your workplace.
You're right. The notes list a bunch of high-risk professions: coal miners, construction workers, firefighters, even hairdressers. Imagine breathing in death fumes or chemicals every day.
It's a reminder of how important workplace safety is.
Absolutely. And let's not forget about tobacco dependence. It's a major risk factor for lots of respiratory problems.
The notes mention nicotine is addictive, so quitting smoking must be really hard.
It is. But the notes also talk about interventions, like nicotine replacement therapy and medication.
So quitting is possible.
It is.
Okay, so section 13 is pleural diseases.
All right. This can be pretty serious.
I have to admit, I don't even know what the pleura is.
Imagine your lungs are delicate balloons. The pleura is a membrane that surrounds each lung, like a protective sac. There's a visceral pleura lining the lung itself, and a parietal pleura lining the chest wall. And only the parietal pleura has pain receptors.
So that explains why pleurisy is so painful.
Exactly. It's those inflamed membranes rubbing together. The notes also discuss pleural effusions, a buildup of fluid between the pleural layers.
So instead of a thin space, it's filled with fluid. What causes that?
Lots of things. Heart failure, pneumonia, cancer, autoimmune diseases. Doctors use Light's criteria to differentiate between types of fluid.
It's like detective work.
It is. Now, the notes also describe respiratory failure. It's a life-threatening condition where your lungs can't give you enough oxygen or remove enough carbon dioxide.
So the lungs are failing to do their job.
Right. And the notes classify respiratory failure into different types based on blood gas abnormalities.
So there are multiple types of respiratory failure.
Exactly. And we're going to dive into those in the next part of our deep dive.
All right, I'm ready for more. This is fascinating stuff. But let's take a break before we tackle the final section. Acute respiratory distress syndrome, or ARDS. I'm intrigued by what we've learned so far, and eager to see what else these notes have for us. Join us in part 2 as we continue exploring the heart and lungs.
Welcome back.
We're back for more. Last time we were about to dive into acute respiratory distress syndrome, or ARDS.
Oh yeah, ARDS, it's a severe lung injury that can develop really quickly and has a high mortality rate. Imagine widespread inflammation and fluid buildup in the lungs, making it so hard to breathe.
It sounds like the lungs are drowning.
Yeah, it's a powerful image, and sadly, pretty accurate. The notes go through the different phases of ARDS: exudative, proliferative, and fibrotic, each representing a different stage of damage.
So it gets worse over time.
It can, yeah. In that first phase, the exudative phase, the lungs are flooded with fluid. It's like trying to breathe through a straw. Then in the proliferative phase, the body tries to repair the damage, but that can actually lead to scarring and stiffening. Finally, in the fibrotic phase, the lungs are permanently scarred and stiff, making breathing incredibly difficult.
It's like the lungs are going through a battle.
Yeah, that's a good way to put it. And the notes highlight mechanical ventilation as being key to supporting breathing for ARDS patients.
So a machine is breathing for them.
Exactly. But even that has risks, and the notes emphasize that it's a delicate balance. You want to keep the person alive, but also minimize the potential complications of the ventilation.
It sounds like a challenging condition to manage.
It is. The notes don't try to downplay how serious it is, but let's shift gears. Let's talk about medications.
All right, I'm ready for that. Medications are a key part of managing all these problems.
They are. And the notes break down all the different antihypertensive drugs, the medications used to treat high blood pressure.
That's a good place to start. Hypertension is so common.
It is. And the notes separate the drugs into different classes, each with their own mechanism and side effects.
So there are lots of options.
There are. And doctors have to pick the best one for each patient.
Okay, so let's break down those classes. First up, diuretics. What are those?
Diuretics, sometimes called water pills, help your kidneys get rid of excess sodium in water, which reduces blood volume and lowers blood pressure.
So it's like flushing out the system.
Yeah, good way to put it. The notes say that thiazide diuretics like hydrochlorothiazide, are often the first choice.
But I'm guessing they have side effects.
Oh yeah, that most medications do. The notes point out that thiazide diuretics can sometimes lower potassium levels in the blood, which is called hypokalemia. That can cause muscle weakness and heart rhythm problems.
So doctors have to keep a close eye on potassium levels.
Exactly. Now, another common class is calcium channel blockers, like amlodipine and nifedipine.
I've heard of those, but I don't know how they work.
Okay, so calcium is key for muscle contraction, including in blood vessel walls. Calcium channel blockers stop calcium from getting into those muscle cells, which relaxes the blood vessels and lowers blood pressure.
So it's like calming down those blood vessels.
Exactly. And the notes highlight how they have fewer side effects than diuretics. Some people might get headaches, or facial flushing, or ankle swelling, but usually it's manageable.
That's good to know. What about ACE inhibitors? Those seem to be popular.
Yeah, they are. ACE inhibitors usually end in epril, like lisinopril and enalapril. They block an enzyme called angiotensin-converting enzyme, or ACE, which regulates blood pressure.
So they're targeting a specific part of the system.
Exactly. And the notes point out that ACE inhibitors can be really good for people with diabetic kidney disease because they protect the kidneys.
That's good, since kidney disease is a serious complication. But are there any downsides to ACE inhibitors?
One common side effect is a dry cough. It's not dangerous, but it can be annoying.
So there's a trade-off.
Right. That's where AOBs come in. Angiotensin II receptor blockers, they usually end in sartan, like losartan and valsartan.
There's a pattern with these names.
Yeah, there is. ARBs work similarly to ACE inhibitors, but they target a different part of the pathway. They block angiotensin, a hormone that constricts blood vessels.
So a different approach to the same problem.
Exactly. And the notes say that ARBs have a lower risk of that dry cough.
Okay, good to know. So we've covered diuretics, calcium channel blockers, ACE inhibitors, and ARBs. Are there other options for high blood pressure?
There are. The notes also mention beta blockers, which are used for various heart conditions, including hypertension.
I've heard of those, but not sure what they do.
So beta blockers usually end in ecolol, like metoprolol and atenolol. They block the effects of adrenaline on the heart. Adrenaline is our fight or flight hormone. It makes our hearts beat faster. Beta blockers calm the heart down, slowing the heart rate and reducing the force of contractions, lowering blood pressure.
So they're like a brake pedal for the heart.
Yeah, good analogy. And the notes emphasize that beta blockers can also be used for arrhythmias, abnormal heart rhythms, and even anxiety.
They're multi-purpose. Any cautions with them?
Yeah, they can make asthma worse and should be used carefully for people with diabetes because they can hide the symptoms of low blood sugar.
So again, it depends on the patient.
It does. The notes also mention some less common drugs, like alpha blockers, direct-acting vasodilators, and centrally acting sympatholytics.
Wow, so many choices.
There are, and the notes really stress how important it is to choose the right one.
It's like personalized medicine for hypertension. Okay, now what about medications for heart attack?
Ah, yes, acute myocardial infarction. In that case, time is of the essence. The notes emphasize aspirin and nitroglycerin.
Aspirin? I thought that was for headaches.
Aspirin actually thins the blood. During a heart attack, a blood clot blocks a coronary artery. Aspirin helps prevent more clots.
So it's not about pain relief.
Right. Then there's nitroglycerin, given as a spray or a tablet.
I've heard of that one. How does it work?
Nitroglycerin dilates the blood vessels, including the coronary arteries, improving blood flow to the heart. It also eases chest pain and helps breathing.
It's like opening up those clogged arteries.
Yeah, good way to think about it. And then there's morphine, which is key for pain relief and reducing anxiety.
So easing the stress of this situation.
Exactly. It calms the nervous system, which reduces the burden on the heart.
So many benefits.
There are. The notes also talk about thrombolytic therapy or clot-busting medications like streptokinase and tissue plasminogen activator. They can actually dissolve the clot, restoring blood flow.
It's like a magic bullet.
It is powerful, but it has risks. It's not for everyone, and there's a risk of bleeding.
This is a tough call.
It is. And the notes really stress how timing matters. The sooner you can restore blood flow, the less damage to the heart.
It's a race against time.
It is. The notes also mention antiarrhythmic medications, like lidocaine, to control abnormal heart rhythms.
So they stabilize the heart.
Exactly. And then there's heparin, an anticoagulant. That helps prevent more clots.
Another layer of protection.
Right. It's often given through an IV and might be followed by oral medications, like warfarin.
It's a multi-pronged approach.
It is. The notes also talk about using beta blockers, like metoprolol, to manage acute MI.
Wait, didn't we talk about beta blockers earlier?
We did. They slow the heart rate and reduce the workload, which can limit damage during a heart attack.
They do a lot.
They do. Okay, let's move on to heart failure medications.
Sounds good.
The notes spent a lot of time on digoxin, which has been used for a long time.
But didn't the notes say to avoid digoxin for hypertrophic cardiomyopathy?
Yeah, it's a bit of a paradox. Digoxin helps the heart pump better, which can be good for some types of heart failure. But in hypertrophic cardiomyopathy, the heart muscle is already too thick, so increasing contractions makes things worse.
So the right tool for the right job.
Exactly. And digoxin has side effects. Nausea, vomiting, vision problems, even heart rhythm issues.
So it has to be monitored carefully.
It does. The notes also cover some newer meds, non-digitalis inotropic agents, like milrinone and dobutamine.
Those are hard to say.
They are. Those are used in more serious cases to help the heart pump, often given through an IV in a hospital.
So for when the heart needs extra help.
Right. Okay, let's switch gears to respiratory medications.
Okay. I'm ready to breathe easy.
The notes focus on asthma treatments. They emphasize controlling inflammation and managing symptoms.
So a two-pronged approach.
Yeah. They highlight inhaled corticosteroids, like fluticasone and budesonide.
Inhaled corticosteroids. Those sound kind of scary.
They might, but they're safe and effective. They reduce inflammation in the airways.
So putting out the fire.
Good analogy. The notes also mention long-acting beta agonists, or LEBs, like salmeterol and formoterol.
Are those similar to beta blockers?
Actually, they're the opposite. Beta blockers block adrenaline's effects on the heart. LEBs mimic those effects on the lungs.
So instead of calming things down, they stimulate them.
That's right. LEBs relax the muscles around the airways, and they're often combined with inhaled corticosteroids.
The 1-2 punch.
Exactly. And then there are short-acting beta agonists, or SABAs, like albuterol.
Oh, like the rescue inhaler.
You got it. They open up the airways really quickly during an asthma attack.
A first aid kit for the lungs.
Exactly. The notes also mention leukotriene modifiers, like montelukast and zafirlukast. They block leukotrienes, which are chemicals involved in inflammation.
Another way to fight inflammation.
Right, and they even mention theophylline. It's an older drug, not used as much now, but still helpful sometime.
Lots of options for asthma.
There are. The notes wrap up the medication section by mentioning treatments for COPD and pulmonary hypertension.
Okay, so COPD first.
For COPD, the notes really stress quitting smoking.
Makes sense.
And they mention bronchodilators, like those used for asthma.
So those relax the airways.
Right. And for people with severe COPD, they often need oxygen therapy.
To help them breathe.
Exactly. Now, pulmonary hypertension is trickier. The notes mention vasodilators, endothelin receptor antagonists, and phosphodiesterase inhibitors.
Wow, those are some names.
They are. They're all trying to reduce pressure in the pulmonary arteries. Remember how pulmonary hypertension is a silent threat? These medications are trying to fight it.
Very targeted.
They are.
We've covered so much ground, from
Right.
heart attacks and ARDS to hypertension and asthma and all the different medications and tests.
It's amazing how connected all these systems are.
It is. One problem can trigger a cascade.
That's why a holistic approach to health is so important.
And the notes emphasize lifestyle factors, too.
Absolutely. Smoking, diet, exercise, stress management, it all matters for heart and lung health.
We have a lot of control over our health.
We do. Okay, I want to talk about those subtle connections between seemingly unrelated symptoms.
Me too. It's like a medical mystery. We're back for the final part of our deep dive into these medical school notes. I'm ready to put it all together now.
Me too. Like putting a puzzle together.
Yeah, last time we talked about the whole picture of health, how everything is connected. But what about those subtle connections between symptoms that seem unrelated? The notes mention those a lot.
Yeah, it's fascinating how our body tries to tell us something's wrong, but we often don't notice.
Like our body is whispering.
Exactly. And those whispers can be important for diagnosing and treating things early.
Okay, so give me an example.
Well, we talked about those thoracic aortic aneurysms and how they can cause things like trouble swallowing or hoarseness. Imagine someone has those symptoms, but they just think it's a cold or allergies.
Yeah, they might not even mention it to their doctor.
Well, right, and that's the problem. Those symptoms could be serious, but without checking them out, they might be missed.
So we need to pay attention to our bodies.
We do. Another example is that nocturnal cough. We usually think coughing is a lung problem, But it can be a sign of heart failure, too?
Yeah, the fluid buildup?
Exactly. So someone might have that cough, but think it's just allergies and not see a doctor.
So our symptoms don't always fit into neat categories.
They don't. These notes really show us how important it is to consider all the systems.
Like being a detective.
Exactly. And speaking of being proactive, the notes talk about regular checkups, even when we feel fine.
Like getting your car tuned up.
Yeah, good analogy. Things like checking blood pressure, cholesterol screenings, even lung function tests.
Catching things early.
Exactly. And the notes also talk about family history. Genetics are important for a lot of these conditions.
Like a roadmap of your health risks.
Yeah, that's a good way to put it. And of course, lifestyle changes. The notes say over and over again that things like quitting smoking, eating healthy, exercising, make a big difference.
We can control our health.
Absolutely. These notes have made me want to learn more. It's just the beginning.
Me too. They've really shown me how complex the body is.
It did.
And how everything is connected.
It is.
I can't wait to do more of these deep dives.
Me neither.
And to our listener, we hope this deep dive has taught you something. Remember, knowledge is power, and even small changes can help. Pay attention to your body. Be proactive. Keep asking questions. We'll see you next time for another deep dive. Until then, stay curious.